Welcome to Advanced Hemodynamics Part 2. This is going to be video 2. So we just talked about arterial lines, and now we're going to be talking about another form of hemodynamic monitoring that's also going to be one of your best friends if you are in an ER that uses this or in an ICU. You can find this on pages 94 and 95 of your Nurse Workbook 2.0. And the purpose of this is to provide you with so much more than just the workbook alone, but not only walk through these activities with you, which you can print the pages below this video, but give you more real world nursing education as well. So let's jump on in to our central venous pressure. So this is also known as our CVP. CVP is central venous pressure. And this is what monitors the pressure of blood returning through the superior vena cava and into the right atrium. So this is an indirect measurement of preload and the patient's volume status. So if we remember from part 1 of hemodynamics, our preload is the volume that fills up in these ventricles right before ventricular contraction that's gonna stretch those cardiac muscle cells. And if we look right here at this little central line, this is going to be sitting right here in our superior vena cava. So this specific central line is going to measure the pressure of blood that's coming through here and enters into the right atrium. This is why this is an indirect measurement of preload and the volume status, because preload is that measurement of the volume filling up in the ventricles. So if we have a patient with severe congestive heart failure or a patient that has maybe severe dehydration, maybe to a level of shock, we'll be able to measure this fluid volume status. So this is going to be so helpful to see the overall fluid of a patient. And our normal range is going to be 3 to 8 millimeters of mercury, but this can also be dependent upon the patient's condition. So for instance, in cardiac tamponade, we might see this level around 10 to 12. So that would be a normal CVP for that condition. And when we look at a CVP waveform, there's 3 peaks and 2 descents that are going to make this a complete waveform. However, we're going to go over the 3 main peaks we see on the CVP rhythm to keep it basic. This first circle at the top peak of this wave is going to be our A peak, or our atrial contraction. So this indicates the end of atrial filling and the push of blood into the right ventricle. And the next peak we're going to see is our C peak. So this is going to be when the tricuspid valve is closing. But more specifically, this is going to be when that tricuspid valve is not only closed, but bulging up into that right atrium. And this is due to the ventricular contraction. So the brief increase of atrial pressure because of the ventricular contraction. And our last peak is going to be this V notch. And this reflects the atria filling again when the tricuspid valve is closed during ventricular systole or contraction. So it's the peak of this pressure before the tricuspid valve opens again. So instead of that bulge that we were thinking about in our last one where the ventricles contract, this one's going to be where the atria fills and that tricuspid valve is actually feeling that filling pressure. So the CVP wave is going to show us the atrias contract, the tricuspid valve is closed and bulging up into the atria due to the ventricular contraction, and then the atria refills and does it again. So a high CVP, we're going to think hypervolemia or a right-sided heart failure, or maybe even pulmonary hypertension. And a low CVP, we're going to think of hypovolemia or low venous return and vasodilation. And what we need to remember, and one of the most important things, is that our CVP must be attached to the distal port of our central venous catheter. And this is because that distal lumen is the largest lumen in terms of diameter, but it's the closest one to the heart. And most of our central lines that you're going to see today, it's going to be that brown hub on your central venous catheter, but on the little lumen part, it will tell you which port is distal. Now we're going to move into our SVR, or our systemic vascular resistance. So this is the pressure that the left ventricle has to overcome to get blood out of the heart. And this is manipulated through vasodilation and vasoconstriction. So it's the resistance of blood flow among in the vascular system, not the pulmonary system. So this sounds a lot like our afterload, right? But not exactly. So our SVR is going to be the overall resistance, the systemic resistance that has to be faced, and it's not anything to deal with the pulmonary system at all. And our afterload is going to be really the pressure that the heart is up against in order to eject the blood flow. So if we look at our heart right here, we're going to see that this is our left side of our heart, and the left ventricle is going to push blood out to the aorta and around the body. So it's the resistance it's going to face to push this blood outward. We can calculate SVR by using our MAP minus the CVP and times it by 80 and divide that by our cardiac output. We like to see an SVR range from 700 to 1500. A high SVR is going to indicate that there's an increased resistance within the body's systemic arterial system. So a high SVR could be caused by hypovolemia, hypothermia, and the effect of vasopressors. And I totally get it. Why would a low blood volume or low temperature or lowering that cause a high systemic vascular resistance? Well, this is because our body is actually trying to protect itself. It's doing something called a compensatory vasoconstriction. So what that's doing is it's actually tightening up. It wants to keep adequate blood pressure. So the little bit of fluid volume it has, it's going to tighten up to perfuse everything inside and maintain that pressure. And this also means that high SVR is going to equal a low cardiac output. And a low systemic vascular resistance means there's neurogenic or anaphylactic shock or maybe vasodilation going on. So this means it's easier for that left ventricle to eject blood out of the heart. And then we have pulse pressure. And this is the condition of blood vessels by measuring force generated by contraction. So we're going to calculate the pulse pressure by taking our systolic, so we're going to pretend it's 120, and minus it by our diastolic, and we'll pretend that's 80, which is going to give us a 40 of millimeters per mercury. A high pulse pressure or wide pulse pressure, the higher, indicates that there are stiff vessels and narrowing of the arteries. And a low pulse pressure or narrow pulse pressure can indicate that there is poor cardiac output. And the last part is not found in our workbook activity, but we have two measurements of oxygen saturation in the blood that tells us the balance between oxygen delivery and consumption in the body. So our SVO2, which is going to be our venous oxygenation saturation, measures oxygen saturation in the blood returning to the heart from the entire body. So we collect this from our pulmonary artery, and we're going to get into that in our next video. And our SCVO2 measures oxygen saturation in the blood from the upper body, and we collect this at the superior vena cava or right atrium. We can get this from either our central line or our PA line, and we're gonna get more into all of this in the next lesson where we go over our PA lines or our pulmonary arterial lines. So I will see you in lesson 3.